Good day, everyone. My name is Wazir, and today I'll be talking about arthrogenic muscle inhibition. All right. So, following acute knee injuries or acute flare of arthritic knee condition, as well as post-surgical procedures of the knee, there's an observed reduction in maximum muscle size, strength, and activation of the quadricep of the injured knee. And this condition or this phenomenon is dubbed as arthrogenic muscle inhibition, or AMI. Now, AMI greatly interferes with post-operative rehabilitation or treatment and recovery of the injured knee. And the reason why this happens is because of a common pathway, which is the activation of the sensory receptors in the knee. There are two groups of nerve receptors or afferent fibers in the knees. The first one is group 2 afferents, and the second one is a combine between group 3 and group 4 afferent fibers. So, the group 2 afferent fibers behave in the ways of a mechanoreceptors. It only makes up around 15% of all the sensory receptors inside the knee, and it is thickly myelinated and has no free nerve endings. As such, as mentioned just now, it behaves in the way of a mechanoreceptors, which is sensitive to stretch and pressure. The second population, which makes up the overwhelming majority of the population of receptors in the knee, which is the group 3 afferent fibers, which is thinly myelinated, and group 4 afferent fibers, which is unmyelinated, both of which has free nerve endings and as such behave as nociceptors. Now, there are a couple of mechanisms on how these receptors are activated. But before we get into that, let me share some facts about AMI. So, for the longest of time, people thought that AMI only occurs on the affected knee. But based on studies, it is shown that even the contralateral uninjured knee can experience AMI, although to a lesser degree. But a lesser degree in mind, it can reach up to 16 to 24% of the AMI on the affected limb. As a matter of fact, the AMI on the uninjured limb can stay for up to 4 years after the initial joint damage. And this highlights the need for a bilateral approach in rehabilitation of the knee and not just focusing on the injured limbs per se. Now let's take a look at the causes of the activation of the afferent fibers, which leads to AMI. So some of the main causes include swelling, pain and inflammation, as well as laxity, and we will visit that one by one. So the most common and probably the best evidence for the cause of AMI is swelling, and this has something to do with the mechanoreceptors that I mentioned earlier. So studies have shown that injecting even as little as 10 milliliters of fluids into the knee is able to cause notable inhibition and bring about AMI. If you bring it up from 20 to 60 milliliters of infusing the knee with fluid, the maximum isokinetic torque decrement increases up to 40%. And based on a study in 2008, which investigates the effect of intra-articular aspiration, it is found that after aspirating 150 milliliters of fluid from the knee, it is able to bring about an increase of up to 400% of the maximum torque of the quadricep 1 to 2 hours after the aspiration. All of this suggests that swelling plays a pivotal role in bringing about AMI, which goes to show just how important it is to tackle swelling, acute knee swelling, when it happens, to reduce the effect of AMI. The second one is pain and inflammation. Now, we lump this together because they are related to group 3 and group 4 afferent fibers, which is, as mentioned just now, is the nociceptors. Now, the basis for this comes about when there was a study that investigates aspiration followed by injecting corticosteroids inside the knee. It is found that immediately after aspiration, the maximum torque of the quadricep increased up to 8 Newton meters. But 2 weeks after that, there was an exponential increase of the maximum quadricep torque. And this is coincide with the onset of action of the corticosteroids. Furthermore, there was even a study of injecting 15 milliliters of 15 milliliters of local anesthetic inside the knee, and has been shown to reduce pain as well as amplitude of the AMI. However, the evidence for this is also quite mixed, because there has been studies that show that if you inject 10 milliliters of local anesthetics inside the joint, it only takes care of the pain but has done absolutely nothing to reduce the AMI. The third purported mechanism for this is joint laxity. Now, this is probably the mechanism with the worst evidence, because it only involves animal study. So joint laxity, because of damaged primary knee stabilizers, for example in an ACL rupture, can brought about AMI. Why? Because of the basis of activation of mechanoreceptors, as mentioned earlier. However, this has only been proven in animal studies, and there has to date no human studies made to investigate this effect. Another question that arose when it comes to AMI is, will transcutaneous electrical nerve stimulation help with reducing the effect of AMI post-operatively? The short answer is yes. So what happens is that when you apply TENS, especially in the variants of high-frequency TENS on the quadricep muscles, it helps to reduce the effect of AMI, especially at maximum muscle activation, contraction and activation. So some of the key takeaways from today's presentation includes tackling acute knee swelling and aspiration if needed to reduce the effect of AMI. Second, early contraction of the quadriceps and activation of the quadriceps is important to further reduce the effect of AMI, and there is a role of using TENS to further reduce the effect of AMI. Number three, rehabilitation should use a bilateral approach, which includes strengthening and contracting both quadriceps instead of just the affected, injured quadriceps. So that's all for me. Thank you.